Good afternoon and welcome to the West Berkshire Health Scrutiny Committee. I'm Councillor Rolls, Chairman of the committee. I'm supported today by Councillor Alan Macro as Vice Chairman. Other members of the committee in the meeting this afternoon are Councillors Jeff Beck, Tony Linden and Andy Moore. Council officers and external partners joining us to advise and support the meeting are Marion Angus, Belinda Seston, Amanda Lyons, and we also have Louise Noble, Leila Johansson, Duncan Ford and Councillor Bridgman. And later on from Hampshire Hospital NHS Foundation Trust, we have Alex Whitfield, Julie Dawes, Elliot Nichols, Faye Corder and Wendy Landreth joining us. I'd like to welcome Vicky Phoenix, who is our clerk for this afternoon's meeting. It's Vicky's first meeting. And the meeting is also being live streamed via YouTube and Gordon Oliver is the Zoom host. Before we start, I'd like to explain for the benefit of members of the public who may be watching, that this meeting will be held in a hybrid format, both over Zoom and with members present in the council chamber. During the meeting, I would ask that anyone wishing to speak raise their Zoom hand. All voting will be done by a show of actual hands. Does anybody have any questions before we begin the meeting?
No, thank you.
Okay, we'll start with item number 1, so apologies. May I ask if we have any apologies for absence, Vicky?
Yes, Chairman, we have apologies from Councillor Howard Wollaston and from Andy Sharp.
Thank you. Moving on to the minutes of the last meeting. Has everybody had a chance to have a look at the minutes? And do we have any comments? Councillor Bridgman.
Thank you, Chairman. From the floor, as it were, 2 comments on these minutes. One is that I'm not listed as attending in any fashion, and I'll come back to the question of attendance in a moment, but I was clearly there. I appear on the Zoom and I'm in the minutes as commenting. So yeah, I was there. My general comment, and this is something I've raised with Sarah Clark about minutes of committees generally, not just health scrutiny. I think we need to tidy up the way in which members of the body, other members of council are present, officers are present. You know, effectively, we've got members of the committee in the room, members of the committee virtually, other members in the room, other members virtually, officers in the room, officers and often other outside body members virtually. So that's being looked at by Dem Services, but I simply mention it because it's not clear from the also present as to whether people were zooming in or not zooming in, and that can make the reason I make this point is that so far as members are concerned, that can be make a critical difference to the 6-month rule. You know, if you are another member, you're not on the body, but you're in the room. Generally speaking, that's counted as attendance, and that therefore goes to your time under the Local Government Act. So I simply mention that for officers to maybe have a discussion with Dem Services about how we're recording this stuff. Thank you.
Thank you, Councillor Bridgman, and I entirely agree. So, members, may I confirm if the minutes, subject to those comments from Councillor Bridgman and those amendments, can I confirm if I can sign the minutes as held on the 10th of November can be approved as a true and correct record of the meeting? May I have a proposer? Councillor Moore. Thank you, Councillor Linda's seconder. And if we can just have a vote on that. Thank you very much, members. So I will sign the minutes. Thank you. Moving on to item number 3. Can I ask if members have any declarations of interest relating to items on today's agenda? No? Okay. Moving on to petitions. Vicky, may I ask if we have any petitions today?
No, Chairman, no, we've received no petitions.
Thank you very much. Okay, so moving swiftly on to item number 5, I'd like to very much welcome the external partners to this meeting. So we have Louise Noble, who is Head of CAMS and Beds, Leila Johansson from NHS Berkshire West CCG, and I believe Duncan Ford from Oxford Health. And I'd like to invite Louise Noble and Leila Johnson to present your reports. And just for the benefit of those members of the public who may be tuning in, Louise has been asked to give an update on the CAMS Tier 4 service, which moved from an inpatient facility based at Wokingham Hospital to a community-based model in April 2021. And Lola has been asked to update on the progress on the local transformation plan for children and young people's mental health, which was adopted in September 2021. So ladies, the floor is yours. Thank you.
Thank you. So if I start with CAMHS Tier 4, if that's okay. I don't know whether or not you would like me to try and share the presentation that I have, or if somebody's able to share that on my behalf.
I'll just check with the clerk.
I can share it for you if you would like, or you do have permission to share.
It would be helpful if you wouldn't mind sharing it for me, if that's okay.
Okay.
That's brilliant, thank you. So as has been explained to you, I was asked to give an update on the CAMHS Tier 4 new service model that we implemented. It actually went live in May last year. CAMHS Tier 4 services are the sort of tip of the iceberg really in terms of CAMHS care, so primarily inpatient care for children and young people who are presenting with a mental health disorder that requires treatment in hospital, and for which we are confident and have evidence that hospitalisation and acute hospital treatment will be the right setting and will be able to enable that young person to move towards recovery. If I could have the next slide, please, Vicky, that'd be really helpful. I thought it would be helpful to just set the position for you. So CAMHS Tier 4 services are now commissioned by provider collaboratives. We are part of the Thames Valley CAMHS Tier 4 provider collaborative. The lead for that provider collaborative is Oxford Health, hence Duncan being here today, in case there are any questions specifically about the collaborative that he may be better placed to answer. Provider collaboratives were, the programme of provider collaboratives were led by NHS England, and the objectives of provider collaboratives are about ensuring that we provide care close to home for young people where possible, and we really maximise that. We work very, very hard to reduce the number of times where we have to send young people out of our area, which is the Thames Valley, and you can see geographically that on the map in front of you. To ensure that patient experience is maximised and quality is improved, and that we learn from each other and share best practice, and in the provider collaborative are reinvested locally to provide further improvements. And so as part of the Thames Valley Provider Collaborative, we have a number of units that do provide inpatient care. So we have the Highfield unit in Oxford, which provides 18 beds for general adolescent admissions. We have access to the Huntercombe unit at Maidenhead, which has 60 beds, 29 of which are psychiatric intensive care, 11 are general adolescent, and 20 are specialist eating disorders. We have Marlborough House in Swindon, which provides 12 general adolescent beds. And then our Phoenix unit, which is now a day patient and intensive home treatment service, that provides support for up to 16 young people at any one point in time, with an expectation that about half of those will be young people needing general adolescent inpatient Tier 4 care, and about half of those will be specialist eating disorders care. Across the provider collaborative, we have a new eating disorders hospital at home service, which is providing intensive Tier 4 level support for young people with eating disorders who can be supported whilst in their own home, so rather than in an inpatient unit or attending daycare. And then we also have a new PQ unit, which is psychiatric intensive care unit, opening in Oxford on the Highfield site in late 2022. So there are a number of different types of CAMHS Tier 4 units, as you'll see from that summary. So just a very quick summary about Phoenix. So CAMHS Phoenix, we previously had a 9-bedded general adolescent unit at Woking Hospital, and with support from NHS England and the provider collaborative, we transformed that to a 16-space day hospital and intensive home treatment service, for young people who meet criteria for the CAMHS Tier 4 service. So the service specification is the same. It's an intensive treatment service for young people whose needs are at that level. I've already said it was designed for young people who would previously have been potentially admitted to Willow House, which was the GAU, but because we were seeing a significant increase in need in young people with eating disorders, and we were seeing more and more of our young people needing to be placed in inpatient beds out of county, and also finding that actually they weren't necessarily getting better in the way that we had hoped, we looked at how we might be able to support eating disorders patients differently through this new service. The service has core operating hours of 8 AM to 8 PM Monday to Friday and 9 to 5 Saturdays, Sundays and bank holidays. So when they first come into the service, young people actually are able to attend. They come in at 8 o'clock in the morning and they stay with us until late at night and they go home to sleep. And then at weekends, there is a mixture of young people coming in and us being able to support them at home. And then we do provide support for families and young people out of those hours, which is provided via an on-call rota and access to our crisis support service, because generally it's a crisis that results in a young person needing support outside of those hours. So if I could have the next slide, please, Vicky. So what we offer is assessment and care in line with the national specification for CAMHS Tier 4. And specifically that relates to young people who need general adolescent and specialist eating disorders care. And so our service is aligned with the NICE clinical guidelines. We're providing evidence-based interventions. So we provide multidisciplinary assessment, formulation of a young person's difficulties, diagnosis where that's needed. We provide interventions that are both individual and group. And we have a very, very strong focus on working with families, so that all of our programmes, what we're teaching the young people, we're also teaching their families and their carers, so that they know what they need, how they can best support their young person at home. We obviously provide a full range of health interventions, including consultant psychiatry, kind of medication initiation and monitoring, nursing. Very, very significant amount of time is spent in the eating disorders programme on meal planning, supervision and dietetic advice. We still have a school on site, so the young people who attend the unit go to school, and that school is hosted as part of the Wokingham education provision. And the school staff work very, very closely with the young person's home school to ensure that they're able to continue their education appropriately while they're with us. And we work jointly with other professionals, so we work very collaboratively with our CAMHS crisis team and our CAMHS community care teams. Young people should really be in Tier 4 care for as short a period of time as possible. But we also work very closely with education, with social care colleagues and with the voluntary sector. Our average length of stay for the first year we anticipated would be 115 days, which is about 16 weeks. And ultimately our goal is to get our average length of stay down to 91 days, so 12 weeks. If I could have the next slide, Vicky, please. So just to give you a flavour, we are a multidisciplinary team providing very intensive care. So we have a wide range of staff, including social workers, education staff, support workers, as well as the range of therapists that you would expect to see in a CAMHS Tier 4 unit. If I could have the next slide, Vicky, please. And the next slide, which I appreciate is very difficult to read, just gives you a flavour of what the service provides for a young person over the course of a week. So the teams start at 8 o'clock in the morning. Most young people arrive between 8 and 8:15. We have a debrief with parents so that we can understand what's happened for that young person overnight, if there are any issues or challenges or ways in which we might need to adapt their care plan, or factors that we need to build into the support that we deliver across the day. Young people are supported through breakfast. For those struggling with an eating disorder or disordered eating, we have a programme of kind of post-meal support after each of the meals. Where a young person is able to attend school, they spend quite a large part of the day in school. They may or may not come out of school for particular therapy sessions where needed. And then highlighted in yellow, there are a number of groups that we run across the course of the day. So a lot of young people who need our support are presenting with emotional dysregulation and self-harm. So we have specific groups based on dialectical behavioural therapy, where that are focused on managing moods. We have groups that are focused around the eating disorders care, including food and nutrition and body image difficulties. And as you can see, there are parent groups and groups around kind of preparing for the weekends, as well as individual sessions and support for young people. So that's both individual therapy and kind of care planning activity. So if I could have the next slide, Vicky, please. So just some examples of the young people that attend. So young person with anorexia, significantly underweight, losing weight in the community despite the kind of intensive support that we're able to provide in the community, needed daily support, needed that meal support. One of the things we're able to do through this service more effectively than we were with an inpatient unit is that parents and carers come in and they work with us to provide meal support. So the kind of principle of kind of sort of observe one and then do one. And so we're able to support them to actually through observation, through developing skills, and then they're able to then provide that and replicate that support to their child at home. Young person with severe vomit phobia and obsessive compulsive disorder who previously would have ended up going up to one of the London hospitals and needing to travel up on a daily basis. We were able to work with them in an intensive way in their home in the first instance, and then as actually part of the planned programme, it was important to bring them into the unit so that we were able to tackle some of their OCD behaviours and difficulties by bringing them out into an environment where they were able to experience and challenge and put into practice some of the therapeutic skills that they were learning. A young person with extremely high levels of anxiety, some perceptual disturbances, so not to the level of a psychosis, but strong suicidal thoughts and impulses, and a young person with very, very severe depression. These are young people who would previously have been admitted to an inpatient unit and disconnected from their family. And what we've found is that with this less restrictive option, many of our families are very, very keen to be able to support their child at home and to work really closely with us. And what the research evidence is showing is that community interventions for most young people are at least as effective as inpatient care, and for a growing number of young people, what we're starting to see is that they are more effective. So we're able to maintain those connections with home, with family, with friends, and with their local community. If I could have the next slide, Vicky, please. Just some progress to date. So we had, I pulled this together a couple of weeks or so ago, and so we had predicted that over the first year, as we were going through a transition phase, that we would be able to admit up to 34 young people to the unit. When I pulled this together, we had admitted 33. We are now over the 34. So we managed to achieve that 34 by the end of the financial year. We had worked closely with NHS England on the basis that when you create a new service, there is a development period, and we felt that there would be a number of young people that would need access to inpatient care who, in the long run, we would be able to support through this new service. But as we were developing the model, then we may need more people to access inpatient care than we ultimately hope. So we had some additional funding through NHS England to be able to provide those beds that might be needed. We actually have had far fewer young people needing a general adolescent inpatient admission or an eating disorders admission as a result of this change in service model than we had hoped, so we haven't needed to spend that money. What we have seen is a higher number of referrals for young people presenting with an eating disorder than we expected. So prior to the pandemic, nationally there was a growth in the numbers of both adults and young people presenting with eating disorders. And we saw a really sort of significant surge in that number during the pandemic. And so we had predicted on the basis of trend at the time that growth would continue, but it's actually continued more sharply than we predicted. That's very much in line with what's been seen across the South East region and also the national trend. So we're not seeing anything different in Berkshire to what's being seen elsewhere. It is causing us some problems. We have had to review the staffing mix that we have in our service. So we currently have more dietetic time. We've created a job description for a therapeutic cook, because more of the support worker time is being spent on meal prep, and we've had to make some minor changes to the layout of the unit to allow us to accommodate the higher number of young people needing eating disorder support than we'd expected. We had always expected, we've always seen a need for young people to be admitted to an acute paediatric ward for a period of refeeding. What we saw through the pandemic, and again, we've seen nothing different in Berkshire to anywhere else, is an increase in the numbers of young people who present to services very, very late. So very, very, very unwell, with very, very low weight, and in need of acute paediatric support to manage the physical health risks associated with refeeding. And we had several young people who we hoped to be able to support through Willow and not need that paediatric admission, but we did need to admit them for a paediatric support for a period of time. And so we've worked very, very collaboratively with our colleagues at the Royal Berkshire in a way that's different to the way we were able to work before. So we've been able to continue their therapeutic care. They've remained under the care of Willow, and we've had staff going in, our psychiatrists, our psychologists, kind of going in and working with them during that refeeding programme. And we've worked really closely with colleagues at the Royal Berks in terms of training and support for them to upskill them to work with young people with this type of presentation. The number of young people needing crisis support, the number of kind of incidents that we've had has been very, very low, lower than we predicted, which is really positive. The number of incidents of self-harm, which in the previous inpatient model we saw particularly high levels, kind of out of hours really, has been much lower with this new model, and again lower than we predicted that it might be in the first year, given that it was a transition year. We've had no serious incidents during the transition year. And service user feedback from both parents and young people has been very, very positive. And we've been able to talk about this model nationally. We've been invited to a number of conferences to share our experiences nationally with other areas of the country who are developing similar models. If I could have the next slide, Vicky, there's just a couple of quotes from young people that I kind of won't read out for you, but I'll let you have a look at those yourself. So there's that one from Safia, which is obviously a pseudonym, and then there is another one, and that's all I had to say.
Thank you very much. Members, may I ask if there's any questions? Should we just have a read of that final quote? Because I think those quotes are really powerful, actually.
I will just say that Willow House is what we previously called the unit, but we've renamed it as Phoenix because that was what the young people asked. They chose that name for us.
Thank you very much for the presentation. So members, may I invite you to some questions? So Councillor Moore.
Thank you, Chair, and thank you so much for your presentation, Louise. Really interesting. I just reflected on the two quotes you used. You said they were pseudonyms, but I'm assuming that they were both given girls' names, so I'm assuming that they were both girls, and it just struck a question with me. Typically, I would assume that eating disorders, anorexia, tend to be more female than male. That may be a prejudicial view I've got. But is the balance of your patients, how is that balance between male and female, and what sort of strategies does that prompt?
Yeah, we have much, it's very imbalanced in terms of much higher numbers of young females presenting with this level of need. So you're right, in eating disorders, we do see more females presenting, actually through all age groups, than we do males. So we have seen an increase over the last few years in the numbers of young boys and men presenting, but the balance is still in the direction of females. And in terms of the other difficulties that present, we also see a higher proportion of young women presenting. One of the reasons kind of looking at community-based models and enabling people to go home is that we have to think really, really carefully about the patient mix on the ward at any one time, and keeping a group of kind of adolescent young people, particularly where we've got kind of predominantly females on a unit overnight, presents challenges in terms of kind of group behaviour and the development of friendship groups and kind of learning of unhelpful strategies. And I guess with the new model, they're quite timetabled, and then they're going home at night and sleeping at night. And so I think that's probably one of the reasons why we see less of that kind of group focused self-harm type behaviour that we previously saw.
Thank you. Councillor Macro.
Thank you. Thank you for the presentation. It does look very promising. One thing that's always been a bit of a concern to me is the fact that the Phoenix Centre is, I think it's in Wokingham, isn't it? How do young people get there from the more far-flung parts of the county, please? Because it strikes me as that could be very difficult in some cases.
Yeah, it can be. So they do travel on a daily basis. And in fact, actually, we are a unit that functions across the whole of the provider collaborative. So we have Willow House previously as an inpatient unit and Phoenix as the existing service model. We do have young people who travel from outside of Berkshire because of the fact that we serve a wider area. So we've had a number of young people coming predominantly from Bucks and from the sort of closer edges of Oxford coming to the unit. So that's a discussion that we have with the young person and their family. What we found is that obviously families, a lot of the families are really, really keen to keep their young people at home, but we do also look at what support might be available and what support might be needed for a family. So we have a couple of options. We have a social worker as part of the team who will work very closely with local social services in terms of what entitlements there might be that could support that. We also have the ability to be able to go and deliver interventions to a young person at home where that makes sense and where we feel really strongly that being able to support them in their home is going to be better for them than needing to admit them to an inpatient unit. And there are ways in which we can provide some of the care that we provide digitally through digital media as well. So we're able to do a bit of mixing and matching. And then for young people who really do need inpatient care, we still have the opportunity to admit to the inpatient beds that exist within the provider collaborative. So we've had a couple of challenges with PEP families finding it really difficult, but we have kind of managed to overcome those through that combination of different methods so far.
Well, thank you. Is there any kind of help with transport, for families who don't have a vehicle or where the one vehicle is required to get someone?
No, we don't have any ability we don't have any transport. What we do have is the ability to look at how we could support through funding in terms of access to taxis and those kinds of things.
Thank you.
Thank you. Councillor Linden.
Thank you, Chairman. Hi, Louise. I've got a couple of questions. One on staffing resources, but a couple on them, and then a further question about risk, which I'm going to start with. I don't know if the chairman wants me to do all my questions or have a break after them.
Why don't you just start with your first question and then we'll see how we go.
Okay, thank you. Certainly, it's been very topical, and also outside our area, we've had difficulties with young people accessing CAMS type services, particular things on evidence GPs have to provide, for instance, on suicides and things like that. That was on BBC News. But the question you can answer that. The question I'd like to say was that there was a survey of GPs that shows that high-risk referrals are often rejected. Half say that at least 6 in 10 referrals they make for anxiety, depression, conduct disorder and self-harm are routinely rejected because the young people's symptoms are deemed not severe enough, even though they only refer the most at-risk cases.
So you're moving into more general CAMs rather than tier 4. And I wonder if that's a question that might be better answered after we've had Lila's presentation on the local transformation plan. Because my Berkshire Healthcare Trust provide some CAM services, but actually there's a much wider system of support. And we can, within that presentation, I think, talk about the increasing demand that we're seeing and what we're doing about that.
Let's pick that up in that piece.
Okay.
Yeah, Councillor Linden, did you have another question?
Yes, staffing and resources, that comes under your providence, isn't it, Louise?
If you want to ask about the tier 4 service, I'm quite happy to answer about the tier 4 service now, and but if it's about broader CAMs, maybe we pick that up again after we've had the rest of the presentation.
Okay, that's fine. So I'll leave that on because I think there's some other people who want to speak on tier 4, Chairman.
All right, thanks, Councillor Linden. Councillor Moore.
Thank you again, and just coming back on something slightly different, and this is really on this model of the at-home service, and obviously the demands that then places on parents and carers, and a little bit, if you could, on how you support them. And also, then I think this issue of, well, is it better to be, an inpatient or an outpatient, and how much choice families have in that?
So the decision making is very much, does the young person are they presenting with a difficulty that needs and kind of would benefit from care at that tier 4 level? And then are they presenting with a difficulty that the evidence suggests is likely to do well in an inpatient setting or not? And I guess what we're seeing is this kind of emerging growth of evidence that admitting young people to hospital isn't always the right thing to do and often isn't helpful. So it really very much depends on what the clinical presentation of a young person is as to whether or not the multidisciplinary clinical team, in discussion and liaison with their community CAM service and other colleagues, including social care, for example, and whether or not we feel that actually they will benefit from inpatient care. There is obviously some of the factors that are taken into consideration there are the dynamics within the family, who else is within the family, how easy or not it's going to be for the family to be able to support their young person at home, and actually the impact of the family on the young person's difficulties as well. So in an eating disorder, for example, the evidence-based intervention is a family-based intervention, and that's what all the clinical guidance is. But really what we should be doing is working with the family to address the factors that are going on within the family that are perpetuating that eating disorder, and to equip and skill and support the family. So we try to think very, very holistically, and there's a lot of support built in for families in terms of family therapy, in terms of treatment modalities which are based in systemic family practice, in terms of debrief sessions in the mornings and in the evenings, in terms of access to the clinical team 24 hours a day, 7 days a week.
Very interesting.
Thank you.
Very
may I just ask you one question? I can't see any other hands up from members. Can I ask you more generally what the reasons were for moving an inpatient facility to a community-based service for tier 4, and if there's any disadvantages to the community-based approach?
There were a number of reasons for moving to a different model. One of those was learning from the provided collaborative early implementer sites. So this was an NHS England programme that was implemented in the north of the country in the first instance. And what the early implementer sites were starting to show was that young people were doing better if they were supported in the community. There's been some research done by the South London and the Maudsley, and we're actually engaged in some of that research now that is showing that young people were doing better. And then BEAT, the National Eating Disorders Charity, had done some research. NHS England had also undertaken a review of demand and bed needs across the South East region. And what they'd come to the conclusion of was that because of the emerging evidence base and the success of community models, they didn't really need to build a new general adolescent unit in Berkshire. Willow House, there were limitations in terms of what we were able to do to meet the standards and recommendations for a 24/7 inpatient unit. It always had a shelf life, and we've been running a unit there kind of beyond that shelf life. So we've been working with NHS England on plans to build a new unit. But actually what the modelling across the South East region identified was they didn't need more GAU beds. What they needed was psychiatric intensive care and kind of specialist LDA beds. And the sites that we had available in Berkshire weren't suitable to build that type of provision. And so it just made sense really to look at how could we meet our local population needs differently.
Thank you, that's very helpful. Councillor Macro.
Thank you. Yes, as I mentioned before, it was a very interesting and informative presentation. But could I make a plea, please? Acronyms. Somehow could the meaning of an acronym be introduced, preferably in text at the beginning? For example, ED, I looked that up and it could have meant emotionally disturbed rather than an eating disorder.
Eating disorders, yeah.
So please.
Thank you, Councillor Macro. I think that goes across the board actually for all the reports. So thank you for raising that. Councillor Moore.
One final question. Thank you. I was interested in the educational provision you're trying when the pupils are attending you on a daily basis to give them to continue their education. How does that work where you need specific facilities, sports, laboratories, that kind of thing? How do you approach that?
So we have a school that is a school within the Wokingham Borough Council provision. So it's registered with Ofsted and inspected by Ofsted. And actually it's the most recent inspection, I believe, gave it an outstanding rating. So we do have classroom facilities. We do have outside space. We don't have outside space that enables young people to do the full range of sporting activities that you'd expect they'd be able to access in a usual school, but they are unwell. They are with us because they are unwell. And so no CAMS kind of inpatient provision would have those facilities either. It's really about trying to ensure that we maintain their academic progress, and for young people who are potentially progressing towards exams, for example, to maintain that kind of syllabus teaching. So there are limitations.
Thank you very much. Members, any more questions? No, thank you so much, Louise. May I now invite Layla to give her presentation on the local transformation plan? Layla, the floor is yours. Do you want us to share your slides?
That would be wonderful. Yes, please.
Are you able to do that, Vicky? Bear with us.
Okay, pleasure.
There we are. We're just about to bring them up.
Oh, not terrible.
Can everyone see those?
Yes, thanks very much. So the Children and Young People's Mental Health and Emotional Wellbeing Plan is a requirement through NHS England. So each CCG, and you may well already be aware of this, has to have a local transformation plan that gets refreshed every year. The requirement for further refresh finished last year during 21-22, and we're just awaiting information through NHS England about what their future ambitions are around whether this kind of process continues or we will move into a new sort of assurance model. So this is very much part of the children's mental health long-term plan assurance, and the plan really is designed to not just look at what happens within mental health services, but also how we work with partners, local authorities and third sectors in developing emotional well-being and more specific mental health support to children. So I'll just go through very quickly what the priorities are in the plan and what we've achieved so far, so we can leave enough time for questions at the end. So do you want to move on to the next slide, please? So here's just an outline of some of the things that we've been working on. So we've been working on establishing MHSTs, and that's mental health support teams in school, and is part of a national program improving access to mental health services, which is very successful. The national ambition has been to have 25% coverage across England by 23-24 in the programme, and locally, and I'll come on to that, we've now got 52% coverage across all primary and secondary schools, so we're a bit of ahead of some other areas. And as Louise alluded to, there's an intensive community and home treatment service that's being developed that is integrated into the wider CAMS service, and included in that is what they call the rapid response service. And in terms of the long-term plan and the future around crisis responses, there is a requirement in the long-term plan to develop specific 24/7 crisis support services for children and young people that they can access. And again, throughout the pandemic, there was a further development around access through a 24/7 telephone line, and that's now been established. So if you go through NHS 111, you get routed through to that crisis line. The other thing is about improving outcomes data that flows into what's known as the mental health service data set, which is a national data set that all mental health providers flow data into. And the intention is to start being able to evidence the outcomes that children have when they attend mental health services. And some of that work is very much underway. A piece of work around digitalising the Little Blue Book of Sunshine that you might be familiar with has taken place, and that is now available as a hard copy across all the schools, but also through Android and through iPhone, what they call apps that people can download. And we're just debating at the moment whether we want to do a refresh in terms of prints, or we want to go out and promote the apps a bit more proactively. Another thing is the Children in Care offer has been co-produced with children and local authorities and Berkshire Healthcare Trust, and that is now entering into a mobilisation phase, and we can talk a bit more about on the next slides. Also launched an ASD and ADHD advice and guidance service. It's a 3-year contract with Autism Berkshire. That's been very successful so far, and in fact we've put some extra funding in through some window funding that we've had available to create a bit more capacity in the system. And part of this plan was to do a quick and comprehensive review of children's services, and purpose of the services was to set the priorities for the coming year. And so if we go on to the next slide, we can talk through those priorities. Just very quickly, I think you will probably be familiar with this because you will have seen the other local transformation plans. So the overall ambition is about promoting resilience. Good mental health and well-being is a priority across all partners. So it is not just a CCG or Berkshire Healthcare a priority, but it's very much that mental health is everybody's business, as set out in the sort of blueprint for children and young people's mental health services. Next slide, please. So just very quickly, there's 9 priorities that were developed through the review. So one was building a formed delivery partnership arrangement, and that's very much underway at the moment, and it's being scoped out by Oxfordshire Mind. And then the ambition to create a sort of single point of access for people. Because what we hear quite frequently from families and other professionals, it's difficult to find your way around in the system and to understand where to go and to get access to mental health support. And then, of course, the Really big priorities about tackling waiting times with both specialist and in core CAMS, and I think we'll come under some questions later on after these slides. And then eating disorder services, there is, as part of the long-term plan, ambitions to have continued investment and to improve access for children and young people who have eating disorders. And then the fifth one is to mobilise the community home treatment team and offer 24 access. And again, that's a long-term NHS England ambition. Next slide, please. And then the sixth priority is about mobilising 2 further mental health support teams. So Berkshire West were awarded through the national programme and the regional NHS England team funding for 2 more mental health support teams, and then they are being mobilised and they will be fully operational from September this year. The staff who have been recruited are just going through the training programme at the moment, and we have regular meetings to make sure that the mobilisation is on track. Then priority 7 about meeting the COVID-19 surge demand as it rises. You've seen the next slide, so that has been stood down. It was a meeting that was established across partners to have live data around what the impact was for children and young people as we went through the experience of COVID-19. Priority 8 was about addressing gaps in access and offer service due to inequalities, and we've have just put a specification out to tender to have a formal piece of work where we would be out and looking at gaps in services and reach out to children and young people who are identified as suffering health inequalities in terms of getting access. And the idea is that once we've got that piece of work done, we will share that with partners and we'll collectively start thinking about how do we then redesign services to go out and address those gaps. And priority 9, strengthening our adolescent and young adulthood offer. So both within the long-term plan, there's an ambition to do better around the 16 to 25-year-olds, because we know that that transition period is where we're not doing terribly well at the moment. So that also fits in with the adult mental health team's community transformation programme, and that is where that discussion is had, and we are still working on what that offer will look like specifically. Next slide, please. And again, here's a bit more detail about where we're at in terms of progress with the different priorities. So we'll have a youth conference that's going to take place on the 18th of May with all partners that we're sending out invitations. And the idea really is that we are starting to have a more strategic approach to telling people what's available across Berkshire West, and not just in terms of statutory services, commission services, but also through third sectors, and start having that Thrive model discussion around how we all responsible for children and young people's mental well-being. There's also a network and partnership meeting that's been established, and we're doing systems mapping at the moment to inform further commissioning. Reducing waiting times is that we, and Louise can talk a bit more about this if there's any questions around it, that there is a transformation lead that's been successfully recruited to, which is very good news. And also Louise's service has done quite a lot of work around developing clinical pathways and pathways on a page, and we're committed to do some more work in terms of reviewing the CAMS service and CAMS specification going forward. And for the children care service specifically, we have now, as part of the mobilisation, recruited to the senior leadership team, and that recruitment continues, and we will be doing a soft launch a little bit later this year when the team has been fully recruited to. And again, we have regular meetings with the 3 local authorities who have also put funding into this service. Next slide, please. And eating disorder specifically is a big national priority because, as Louise alluded to, we've seen quite a lot of activity in that area, and that is really where during the pandemic, we've seen the greatest deal of pressure within services. So there's a lot of work that's happening, just not locally, but also across Buckinghamshire, Oxfordshire, and Berkshire West place. And so we're linking increasingly with the other areas around how we're developing eating disorder services. BEAT is a national charity, and they've been commissioned to deliver training to our primary care partners, and that is taking place and finishing at the end of March. And again, recruitment is nearing its completion, and I think there will be some questions later on around workforce that we'd be happy to answer. There's something also quite significant. It's called the Peace Pathway. And don't ask me what P stands for, I can't remember, but essentially it's making reasonable adjustments for the eating disorder services for children and young people who have disordered eating or who have autism. So what we're finding in terms of young people coming through, where the biggest pressure has been, are young people who have either disordered eating or something called ARFID, which is a type of disordered eating, or your more traditional eating disorders that you alluded to early on. So that is a pilot, and we're doing that on behalf of the region. And I think the evaluation will happen sometime during this year. It's still being mobilised. And as I said earlier, the crisis and home treatment service is being recruited to, and is very much still in the mobilisation phase. New MHSTs, mental health support teams in schools, and the existing teams that we have are starting to have quite an impact. And the national evaluation that's taken place for the national programme has showed that it's having quite an impact in a positive way on support for children and young people. And then finally, the inequalities is that we will have a report ready shortly. Next slide, please. So really just to set the scene, and I think that you might come on to ask some questions around this, is what we have seen is unprecedented levels of increase in referrals to children's emotional wellbeing and specialist mental health services over the last 2 years. You can see the numbers for yourself, an increase of 60% in the last 12 months. And what we're seeing is the complexity has gone up. So we're seeing very, very complex young people coming through. And it's not just within CAM services that we're seeing that complexity go up. When we talk to our social care colleagues and we talk to our third sector colleagues, they are reporting a very similar picture across the piece. Workforce, what we're seeing is a high turnover in some of the clinical workforce. I think it's true to say that it's not just acute services that you've heard quite a lot about on the news, but mental health staff as well have felt the pandemic and have been under significant levels of stress to deliver services in quite challenging circumstances. We have got quite a important and significant investment plans that's coming through NHS England. It's very much part of the long-term plan, and that plan kind of continues until 23-24, and then we will see what happens in the new parliamentary after the elections, what that plan will look like. But we're expecting very much for children and young people that the national long-term plan will continue to have investment going along. When the plan started, the only 25% of children and young people who had diagnosable mental health conditions had access to mental health services. So in terms of access rates, that's now up to about 50%, but it's nowhere near in the way that you would see for physical health services, for example, which are closer to 90%. So there's still a long way to go in terms of investment. And I think what we're finding is that the workforce, we're struggling a bit with the development of the workforce to meet demand that we're seeing. I think my personal view is, had the pandemic not happened, I think with the national programme, children and young people's mental health services would would have been in quite a good place in terms of investment, but the staff needed to deliver the increase in activity are simply not there at the moment, and that is our biggest challenge. Final slide, please. So again, plans for the future is we are anticipating some direction through NHS England about a local transformation plan that will hold us to account around how funding is being spent and how we're working with our local partners. And as I alluded to, is that the CCG and Berkshire Healthcare Trust have committed to review the existing CAM services, and we have an ambition around developing a Thrive model, which is a conceptual framework around how you deliver children and mental health services, which is geared at early intervention, prevention, building resilience, and working with partners to have a early emotional well-being services right through to children that need very specific secondary mental health services. And I think that's the end of the slides.
Thank you very much, Leila, for that very comprehensive presentation. I'm going to open up the floor to members, but can we keep questions as short as possible, because we are quite tight for time this afternoon. Councillor Linden.
Thank you, Chairman. I'll come back to staffing resources. So if I could just do the question that I raised earlier to Louise. The survey of GPs show a high risk of referrals are often rejected. Half say that at least 6 to 10 referrals they make for anxiety, depression, conduct disorder and self-harm are routinely rejected because of the young people's symptoms are deemed not severe enough, even though they only refer to the most at-risk cases.
I can.
Yeah, go on, Louise.
Yeah, I can provide some response to that. So we've got a multitude of different services that provide emotional well-being and mental health support. And so one of the things that we work very hard to do is to try and direct referrals to the right level of service. So a young person who's presenting with self-harm behaviour may not necessarily be presenting with a serious and significant mental illness as the root cause of that behaviour. They may well be presenting with a difficulty that requires an intervention at what we would describe as getting help level under the Thrive model. And so those services are provided by organisations like the Emotional Health Academy and like the Anxiety and Depression Research Clinic at the University of Reading. And so what we try to do is enable referrers to have the right information to be able to direct those referrals to those services in the first instance, and we do work quite collaboratively with them. So when we send referrals back, it's generally because we've assessed their level of need as being best met by another provider rather than ours. Conduct disorder is a very good example there. So Berkshire Healthcare CAMs don't provide a service for conduct disorder. That sits within other local authority services such as the Emotional Health Academy.
Thank you. Councillor Moore.
Thank you, Chair. In one of your early slides, you talked about coverage of the teams across the pupil population, 32% with an aspiration to get up to 52% this year. I wasn't quite clear in my own mind what happens to the remainder. I mean, is the service focused on individual schools? And if you don't have anybody associated with your school, you just simply don't have that service available? How does that work?
Shall I answer that one, Louise? So this is a national programme. So the national ambition was to have 25% coverage, and there might be an error in the slides. And so investment from the government through NHS England was made available at a national level to have enough teams to cover 25% of schools. we've had a bit more than that, so we are now able to meet. I have coverage for about 50% of the schools across Berkshire West. The reason why it's not going to be 100%, or that I believe is the ambition at the national level, is that the teams have to go through training at university. So you can't simply create a new workforce to cover 100% coverage immediately. That is a program that has to take place over a number of years to have enough university places and to have enough staff to get trained over a period of time. So there's some practical things that are stopping us from, it's not just about money, but from reaching that sort of 100% level.
So I guess the follow-up question is how do you choose which schools have got that facility at the moment?
Yes, so there is a structure that we're using that's been signed off by NHS England. So across Bob, we're looking at levels of need, deprivation, and so we're using pupil premiums, deprivation and health inequalities. So we're using a mixture of different tools to help establish where we should put the funding and which schools should be included in the different waves that are coming along. So and we are just going through a discussion at the moment about the final waves for 23-24, and then we send that into the national team and then they sign it off.
Thank you. And Chair, if I may, just
Yes,
one other brief question. Your final slides were sort of your challenges. I wasn't quite sure what the colour scheme was supposed to represent of the different boxes that were presented, but it didn't feel like green overall to me. Would you care to comment on how you come by that? Presumably each of those boxes has got its own rating.
Yes, I don't think the colours were of any significance. So as an overall programme, because I have oversight of it, it's all making the key milestones that we've committed to deliver.
Thank you. Does that answer all your questions, Councillor Moore? Thank you. Councillor Macro.
Thank you. I was a bit surprised that tackling waiting times is only priority 3, because we saw at our last meeting the results of a survey done by Healthwatch, where parents were complaining they're waiting 1 to 3 years, and I think in some cases as much as 5 years for intervention. So I wonder why it wasn't higher priority. There's also some terms on the slide that I didn't understand. For example, pathways on a page, and there's also CIC and B8B and B8A. I wonder if you could elucidate, please.
Yes, so I think the pathway on the page, Louise might answer. So CIC is children in care, and the B9 and the B8 are NHS banding. So there's senior management roles within the NHS. But I will take feedback back, obviously, and I think Louise has had to do the same around using acronyms when we're presenting at these forums.
Does that answer your questions, Councillor Macro?
The priority? Why isn't
yes,
a
so
higher
the priority.
priority?
So I think, waiting times is absolutely our highest priority. I can guarantee that. That is our greatest level of concern. I think the numbers are not sort of significance in that context. So I wasn't present to developing the plan at the time. I've just been in post the past 3 months, but I know I can absolutely vouch that the access times for children and young people is our greatest focus.
Thank you.
Can I just ask on the back of that, Leda, what are the current waiting times like in West Berkshire?
I think that is probably one for Louise. You'll have the latest data around it.
Yeah, it really varies depending on what it is that you're referred for. And what we have is very, very, very good data in terms of time to contact, but not necessarily the depth of data we need in terms of time to specific interventions. And where we've talked about pathways on a page and clinical care pathways, part of what that relates to is the creation of electronic pathways so that we can more accurately capture how long a young person is waiting for the specific interventions that they might need, rather than just the number of contacts that they might have. So it's quite difficult to give an answer to that. In terms of, so the crisis team, if you're referred to the crisis team, you'll be seen within hours. If you are referred, our targets for urgent referrals for first contact, we were achieving 2 weeks, but with the vast increase in the number of referrals that we've received, it's now nearer to 6 weeks. And then for first contact for young people who are more routine referrals, we're nearer to the region of 12 weeks. Where I think Councillor Macro, it might have been referred to sort of 3 years and 5 years. Those waiting times usually relate to neurodiversity services rather than specialist mental health services. So with specialist mental health services, we are usually talking about weeks to some form of first contact, but it can be months for some of the specific interventions.
Thank you very much. And I think we have a final question from Councillor Linden.
Yes, Chairman. I'd like to start before I ask my questions. I welcome the priorities you've set. Also concerned about the high turnover and staff leaving, which is also a concern throughout the health service, including GP services. But it's coming back to staffing and resources. We've had pre-COVID mental health staff increased by about 1% a year over the last 9 years. Demand has increased over 90%. And we have a problem of filling those practitioners and are exploring vacancies by other areas like apprenticeships, bursaries, promoting careers to students, etc. There's also a problem in result of the BMA survey of 63% of respondents say they work in healthcare settings which have rota gaps across the team, and 52% say that they're too busy to provide care which they'd like to do on their last shift work. Are there similar concerns to the Trust? And finally, do you have adequate funding? Thank you, Chairman.
So I can probably start answering, and then Louise might want to come in to just finish off. So workforce is a recognised problem across England. It's not just for Berkshire West. I think this area has particular difficulties around recruitment, with being in a high cost area and being quite close to London. So that is difficult, because you can go down the road and you get paid a bit more. And housing is very expensive across the southeast and across the Bob footprint. So that, those are some of the sort of systemic issues that we're dealing with. In terms of meeting the increase in demand, it takes time to train staff. So, these typically, to train a nurse, you're looking at 3 to 4 years, training doctors 5 years minimum. So those are some of the realities that we're up against. One of the actions that we are looking at across Bob is to develop an academy, which would be a specific children's mental health academy, looking at how across the patch we can work together on innovative ways, retaining staff and also recruiting staff, and putting training programs together that will skill people up quite quickly. And also we'll be looking at how we utilize the third sector and how we can skill up the third sector to work alongside our mental health professionals. So there's a number of different things happening in terms of workforce. In terms of the funding, certainly what we saw last year was that there was quite a lot of funding coming down, but actually the services struggled to recruit staff because they didn't exist. So I think some of the gaps that we're seeing is that we can't fill some of the vacancies. So those are some of the realities that we are grappling with. I don't know if you want to add anything, Louise.
Yeah, just within Berkshire Healthcare Trust, I mean, obviously we do have workforce challenges. We're not different to other organisations in that respect. Berkshire Healthcare is the top performing trust of its type nationally on the NHS staff survey. We've just had some high level data And I'm just waiting for the service-specific data to pull down. And what we do is we use that workforce survey to every year we look at each question in detail at service level in terms of actually where are our difficulties, what are our staff telling us about what's supporting them in terms of staying, and we use that to inform our staff retention and wellbeing plans. You asked specifically about whether we were looking at sort of training, but also different types of different sort of sources of staff, and the answer to that is yes. So we have done quite a lot of quality improvement work. For example, a very dedicated piece of quality improvement work looking at our CAMS consultant psychiatry workforce. We're well over 95% recruited to in our psychiatry workforce, which is significantly different to colleagues elsewhere within the South East region, and we're actually now being approached to understand what it is that we're doing differently to retain our psychiatrists. Within our crisis service development, there is a dedicated work stream around how do we work differently with voluntary sector providers, looking at things like social prescribing, kind of youth mentors who, within our clinical care pathways programme, we have been looking at what are the elements of intervention that could be delivered by a different workforce. So we're doing that across all the different kind of areas of clinical practice. Berkshire Healthcare is a global digital exemplar. So we have already a number of kind of digital service provisions, but we're also working with bespoke digital providers to look at bringing in workforce through a digital provision, which is where we're able to bring in staff working different hours, for example, specifically looking at how we can use that to target some of the challenging areas where we have waiting times that are longer than we need them to be, and we know we can't currently recruit the workforce that we need. We have a programme of work around trainees and apprentices, and then kind of nurse associate training, etc. So there's a really wide-ranging programme across Bob, working collaboratively with our commissioners, but also internally within the organisation. No quick fixes, but yes, we are working very hard to be as creative and sort of broad thinking around this as we possibly can.
Thank you very much. I don't see any other hands from members, so I'd just like to thank Louise, Lola and Duncan once again for your attendance and for your contributions, which are very much appreciated. You are more than welcome to stay for the rest of the meeting, or alternatively, do feel free to leave the Zoom. Members, there's no recommendation associated with this report, so we're just simply asked to note the report. So I'd like to move on to agenda item number 6, Basingstoke and North Hampshire Hospital Maternity Services, and welcome Alex Whitfield, the Chief Executive. I think we have Julie Dawes, Chief Nurse, Elliot Nichols, Associate Director, Comms and Engagement, Faye Corder, Associate Director, Midwifery, and Wendy Landreth, Communications Team Coordinator. Very much welcome to you all, and apologies for the slight running late of this meeting. We had these 2 substantive items on the agenda today. And so, yeah, I will pass the floor over to you and invite you to present your report on the maternity services provision. Thank you.
Thank you so much, Councillor Rolls. And first of all, I do need to send Julie Dawes' apologies. If she can join us, she will. But she's got tied up with something at the moment.
I didn't notice she wasn't on the Zoom. Apologies for that.
Yeah, I don't think she is. But Sarah Mussett, who coordinates all things CQC for us, is on the call, so she may be able to answer some questions as well. So the bulk of the talking is going to come from Faye Corder, who's our Associate Director of Midwifery. Really lucky to have her in the organisation, and she absolutely manages our maternity services to a very high standard. We're here off the back, I guess, of two things. One is we did just want to pick up a really useful Health Watch report from a couple of years ago, let you know what we did with that. West Berks Health Watch gave a particular review on maternity services. And then obviously our CQC visit, where we had an unannounced visit from the CQC. They came in one day and they did reduce our maternity rating from good to requires improvement, which was really disappointing. But actually, as I think you'll hear from Faye, the things they'd identified were things that actually we were already busy working on, because we also had identified that in all of the pressures of COVID and staffing levels and things, they were things that we already had plans well underway to deal with. So although it sounds a bit gloomy at the high level, I think you'll hear that there's lots of good things happening in our maternity services. So I'm going to just pass you over to Faye, but I'm here as well to answer any other questions at the end. So Faye, do you want to go through the slides?
Yeah, thank you, Alex, and thank you everybody for inviting us to your meeting. So we've started halfway down the slide deck here.
Are you sharing the slide with?
I've got it.
You got it, okay. So this is just a picture of us everyday life. It's myself sharing the World Patient Safety Day information with one of our community midwives. In the middle is one of my deputies with the student midwife from the Basingstoke site. And the third picture is one of our continuity of carer team leads, Carol, with a mum that she followed in to give birth on the Basingstoke site. Next slide, please, Elliot. So for the West Berkshire women, we have 2 midwives in each of the surgeries in Falkland and Birdwood practice. We have 86 women that are currently booked to birth at Basingstoke at the end of March. In Thatcham, we have women that have at their antenatal and postnatal care provided by Royal Berkshire Hospital, and 23 out of area women opt to birth at Basingstoke in January, 18 in February, and so far we've got 18 booked for March. Overall in the year, it roughly equates to about 236 births and in Basingstoke for these women, and our plans are to recruit 2 more out of area midwives. So this would fit ideally with our 1 to 110 ratio annually that we would need to work towards to provide more care in the community in West Berkshire. So the next slide, please. So the Health Watch report from March 2020 showed that there was 46 respondents. 14 of these women rated the overall care in maternity as their experience as good or excellent. Further 17 rated it as okay, and 9% rated it as poor, which was 4 out of the 46 women, and another 6% traumatic. Overall, 63% of the mothers felt that they got most of their physical needs met. When we unpicked the data further, it was all to do with communications. So we've updated our websites to provide improved communications for the women. We've launched Facebook and Instagram pages as health promotion in 2020. We introduced BadgerNet, which is our electronic medical maternity records, in May 2021. And also embedded into this is some information leaflets that they can have access to throughout their pregnancy and their postnatal journeys. And the complex care plans are available and printed off for the women to take with them when they go to birth at Royal Berkshire, so that we ensure that we have good communications between the 2 trusts, and then the women don't have to keep repeating themselves, depending on who they're seeing from which health profession. So the next slide goes on to the positives from the CQC visit. So the service took into account of the women's voices and feedback through our MVP, who's Mindy Noble. We had multidisciplinary staff working well together, and they saw evidence of that when they did their site visits. We were praised for our medicine management, our culture change programme, which we started in 2020. We have a no blame culture across the service, and we are really inclusive with culture and families, and the partners are involved throughout the pregnancy journey. We're also one of the trusts that allow partners to stay overnight on the postnatal wards pre-COVID. I need to add, we adhere to infection control measures, and we were specifically commended for all the work we did regarding the COVID-19 information that was sent through the national teams to make sure that we kept our women and our staff safe at all times. And we had 100% compliance with our practical obstetric multi-professional training, which is known as PROMPT. Next slide is the must-dos and the should-dos. The must-dos I will go through in more information as we go through the slide deck. So I'll just do a little brief summary of the should-dos. So it was recognised that not all staff had full understanding of the implications for BAME women regarding COVID, and this feedback came predominantly from the hospital staff, whereas the community were much more up to date because that's where all the changes took place. So this included promoting additional vitamin D for women, making sure that they came into the hospital much more routinely, and that the continuity carer teams were launched, 2 extra ones were launched to support these women in 2021. So what we did about it, we did a targeted awareness campaign. We've put some notice boards up with information for the hospital staff, and we recirculated the education video that the community matrons had done for their staff. So we shared the learning a bit more wider, and therefore everybody now recognises what we did and what we're still doing to support these women. The clinical guidelines, we've got about 4 or 5 left that we need to review and update, but we have an active working party to make sure that we complete this task by the end of April. Our appraisal rate, unfortunately, had slipped to about 65% during the time of the visit. Again, this was due to COVID, staff being off sick, a high maternity leave. We've actually done some targeted appraisals with the staff, and we're now at 93% compliance. So we've done a lot of hard work to make sure that all the staff have received a well-meaningful appraisal for them. And again, this included the mandatory and statutory training. The compliance rate had dropped down. Again, that was due to COVID, isolation, sickness, etc., etc. Again, as people come back to work much earlier than what they were doing, we've managed to do mop-up sessions and provide online training, so people at home that could feel that they were well enough to attend was able to participate. So that again has improved our training stats. Regarding the competencies, we have actively reviewed all of our competencies and our job descriptions. We have international nurses that work on our postnatal ward, and we had newly qualified midwives who were awaiting their PIN, so they were working as an MSW at the time of the visit, when we just reiterated that actually they do the job as an MSW until they have their PIN registration through, and then they can work as a midwife. So we just needed to clarify that when the CQC asked us at the time of their visit. So the next slide is broken down into all of the must-dos. And as you can see, we had 64 actions in total. And as the months have progressed, we've completed more and more actions. So 51 are now complete. 5 are open and on track, 1 is at risk partially met, and 7 are currently overdue, which with regards to the equipment checks and testing, that's because we're having to wait for external contractors to come and review some of our equipment to test it. Recording of domestic abuse, that's really difficult for some of our midwives to ask that question at every contact. But however, we've done additional training and documentation in badger notes to make sure that when anybody comes into contact with any health professional, we now have to create an opportunity to make sure that we ask these questions. So as when I go through the slides, we'll see how we've actually increased that compliance for that. Estates and security, again, with estates, it just takes some time to find the finances and to find the staff, again, because they've been hit with COVID, to come and mend our doors or our sinks, etc., etc. But we do keep on top of this, and they do regular walkarounds with us as well, which is really helpful. And the cleaning checks. So again, this is by the domestic supervisors, but we do have those conversations. And again, we do have those weekly walkarounds with them too, to help us to make sure that our environment is clean at all times. So the next slide is about sepsis. So this is what we did to improve our sepsis training. We did a targeted 1-month-long education training videos. We had newsletters and posters displayed, and we updated our clinical skills and drills to incorporate a scenario regarding sepsis. We also did a video link to our social media Facebook platform for our staff. We're currently still doing sepsis audit templates and plans, so we can review on a monthly basis, and 80% of the women from these audits had appropriate sepsis care and their 1 hour of antibiotics once identified. So the picture on the right hand side is the red flags of the sepsis 6. We also put them into smaller ID size information, so all members of staff have one of those in their ID badges as well. The next slide is about the environment. As you can see, the top picture shows what the floors did look like in Basingstoke, and the bottom picture is now with the newly laid floors. The corridors have all been replastered and painted. We're waiting contractors for the sink and splashbacks in the labour rooms. And again, we have regular walkabouts with the estates and infection prevention to make sure that we are doing all that we can to make it a clean environment. The next slide is about the security. So the male and the female changing rooms were accessible, and therefore we put digilocks on there so that uniforms couldn't be taken from this area. We've also wanting to put swipe access onto the theatre doors. We've undertaken live drills on both sites for baby abduction. And we've also do maternity security spot checks, because in each area and each acute site, you have to buzz to be let in. So we make sure that the staff answer the intercom, who they are, and go to the door and actually let people in and check ID badges if they're uncertain. Next slide, please. So emergency equipment, we signed a new standard operating procedure to ensure that the process for the maternity daily equipment safety checks are robust. We also have a staff briefing in the morning, and everybody's allocated a piece of equipment to check. Individual check and stock list for each piece of equipment or the trolley is checked either daily, twice daily, or weekly. The matrons send weekly compliance reports to our clinical governance team, and the compliance report is to continue in 12 weeks of continual 100% compliance has been achieved, and to date we've done 8 weeks out of 12 with that target of 100%. So the domestic abuse, we have created a flowchart that includes how to ask the question, how to gather the information, how to do referrals, follow-up actions, and any useful contacts out of hours, for example, children's services. We've got a new updated domestic abuse policy that's embedded in the maternity guideline, and we reviewed how we document this information on Badgernet so that we can create an opportunity at every contact. We've written the guide, and the training video has all been produced for the colleagues, and they can access this as and when they want to. It's on the intranet, and 90% of the forms completed was we are able to identify that 35% of women have not been asked. So again, it's still a lot of work that we need to do, but the staff are trying really hard. We've also got domestic abuse advisors that go to the community midwives meetings to help support the community midwives, and they also are the point of contact where we refer the women to domestic abuse advisors. They also come and walk the floor so they can meet the staff on the postnatal ward as well. So it's not just community focused. And again, we're doing everything we can to create this opportunity to answer these questions. The next slide is about the red flags and ensuring that we report appropriately. So the red flag poster is displayed, and they are the national red flags that we have to report monthly to the board. And then we've got some local red flags that we just wanted to gather information for our own interests. As you're aware, we are a 3-site hospital, and Basingstoke and Winchester, we do divert internally at times of when we're full capacity or if we have any staffing concerns. And this is to keep the women and babies safe. But we do like to keep an eye on this. It's not something that we would want to do all of the time, but when we need to, this is what we do. And we also wanted to recognise when we call the continuity of carer teams in as well, because obviously if we're calling them in as part of our contingency, we're not allowing women to have home births. So it was just really to make sure that we are doing all that we can to provide the care that we need to. So we manually cross-checked our process and introduced an assurance to be able to accurately report the data exceeds through safer staffing, and again this goes through to board, and every month Alex has questions about this, because it is really difficult to understand when we live and breathe it, for other people to get a grip of what we're actually trying to say. Overall, we're just trying to demonstrate that we're being safe at all times. The weekly red flags are reviewed, and we share this information with our staff at our safety huddles, and the criteria is included on the on-call SIP rep. So any triggers, the matrons can identify it there and then and share with the senior staff. We have a Monday message that we give out on a video, and that goes to the social media platform and the WhatsApp group as well. Next slide, please. The Band 7 training with regards to learning from events. So this is a copy of what our Learning from Events board looks like. So we put up-to-date information on there, what we want to share, and if there's been any learning from instances that we want to discuss. The risk register is displayed in all clinical areas, so everybody is aware of what our red, amber and green risks are. We have monthly learning agreements devised for midwifery and medical staff, highlighting the learning themes. And we pick 3 that we talk about for the whole month. The Band 7 midwives have also been given a one-to-one presentation on their responsibilities to disseminate learning from instances. So they've given a consistent message to the staff at all times. And on the next slide is how we do our daily and weekly compliance checks. So that's what that looks like. A process for reviewing staffing gaps in the 24-hour ahead of the shift. We've had birth rate plus a tabletop review of all the areas carried out, and we've updated our health rosters to reflect staff allocations. And the recruitment plan is that we've just appointed 9 brand new qualified midwives on the Basingstoke site. We're supporting 4 return to practice midwives who will be qualifying in September. We're actively recruiting and part of the International Midwives campaign, and we should have 10 midwives landing with us in July, and we've got dedicated clinical educators to support them going forward. We've got 1 nurse who's on our shortened conversion course who will complete that course in next year, and we've got 20 students qualifying at the end of September. So we'll have 42 midwives by the end of October, and that will then leave us with a gap of 8 whole-time equivalents that we will need to find after October. So the next slide is about leadership and culture. So at the moment we have an improvement director called Sally Batley. She's an independent improvement director supporting myself and the clinical director. We also have an improvement manager from NHSI England to support with the CQC improvements, because every maternity service that is downgraded following a CQC visit has one of those allocated to them to help them move forward and progress. We have a culture change programme, a behavioural framework workshop where all the midwives designed what that would look like going forward, and the staff development programmes. We have medical leadership and job plans and coaching workshops to support the medical team, and the multidisciplinary team and the governance meeting has all been robustly enhanced over the last year. The Band 7 midwives in charge have had focused leadership sessions and development programmes, and I regularly do Q&A sessions, listening events and regular walkarounds where we do temperature checks on all the staff. The next slide, please, is about the challenges. So every hospital has had challenges with COVID and staffing, releasing staff for training, and obviously staff morale has been a little bit low. We seem to be turning a corner. Our staff have been really great at doing extra shifts for us, and they've been really supportive with the changes we've had to make with CQC. We have joint engagement sessions with the medical staff in. We are consistently changing everything across the three sites, and the Badgernet and the local changes have not been easy, and change requests do take time because we have to go through the LMNS, so it takes about 3 months to make a simple change into our Badger notes, and the environment is something that's ongoing. So our should do's are our clinical guidelines. Like I said, we're trying to keep up to date with those, and we've got targeted focus groups to ensure that happens. Uniform and badges, practice development team reminding the preceptorships what to wear when awaiting their PINs. Appraisals, that's been a real success for us, and I'm really proud of the work that my team's done to make that up to 93%. Again, the COVID-19 leaflets have been updated, and the targeted training has been helpful, and the mandatory and statutory training is also on a trajectory which we're making good progress with. The next slide is about the Ockendon compliance, and this is part 1 of the Ockendon. So this was the 7 essential and immediate actions. As you can see, over the year, we've gone from ambers to green in all areas apart from the last one, which was the maternity workforce planning. What sits under that one is about guidelines being 100% compliant, which we know we're not just there just yet, but hopefully by the end of April. And we've got ongoing work going on at the moment with regards to updating our websites, and then that will turn us to green, and we will then be compliant with all of those 7 and immediate essential actions. So what's next after the CQC is that we want to make sure that we sustain all these changes, and therefore we want to turn these into QI plans. We want to provide excellent patient experience. We want to be continuing with our leadership and culture. We want to be visible, and we want good behaviours. The education and training for the Band 7 development is a succession planning from our 6s to 7s, and we want to optimise learning across maternity for all bandings. And the environment needs to continue to be monitored, and excellent governance and improving our services is the top of our agenda. And I think that is me.
Thank you very much. Thank you very much for that very comprehensive presentation. I seem to have a bit of problem with the microphone. May I invite members to ask questions? Councillor Macro.
Yeah. One of the kind of themes running through the CQC report was issue of staffing. Either there was a lack of staff or lack of appropriate grading of staff, and staff who were performing tasks beyond their competency. I just wanted an assurance really that with this kind of recruitment campaign you've got going, that those kind of problems are going to go away.
Yeah, if Faye can provide a bit more of the detail, but one of the measures we look at board is the number of midwives we say we need and the number we've got. And what's happened over the last 2 years is the number we say we need has increased significantly. And that's with things like Ockenden and Better Births and things coming in saying you need more midwives for the same number of babies, because actually you're doing more checks, the mums are more complex sometimes, and a whole load of reasons why you need more midwives for the same number of babies. So as that requirement has gone up, our actual midwife numbers have gone up actually, but the vacancy number that we talk about has also gone up because the demand's gone up. What's been happening over the last few months is that actually our recruitment and retention has exceeded the growth in requirements, so that we're closing the gap. And I think the numbers that Faye talked about coming in over the next few months, which obviously the plans to recruit those people started months and months back, and some of them started their training courses several years back, those actually mean that by the autumn we'll pretty much be where we need to be in terms of full recruitment. But we have been chasing a moving target over the last couple of years. Yeah.
Thank you. Councillor Linden.
Thank you.
Thank you, Chairman. I think, as you said, Alex, that the Oxen report is a wake-up call, and it is very, very worrying throughout the whole country. And certainly the Sunday Times indicated that that trust could face charges of corporate manslaughter. So this is how serious it is. I do welcome the progress that you've outlined through Faye, but it is important that we assure mothers as well as partners and other people associated with the birth experience. The question I have two of them actually, so I'll mention them both at the same time. Still, birth rates are higher for Black and Asian mothers, older mothers, and those from deprived backgrounds. The MBRRACE UK report published October last year. How are you addressing this? And secondly, midwife shortages are leading to some trusts suspending home birth services. Is this happening in Basingstoke? And also, if you know about the Royal Berkshire, thank you.
Yeah, I can't comment on Royal Berkshire. In relation to the second point, I mean, Faye can confirm the exact numbers, but we do occasionally have to suspend home birth services because actually the safer thing to do is to bring the midwives in. But I don't know, do you want to say a bit more about that, Faye, and about the stillbirth question?
Yeah, so the home birth service has been suspended predominantly over the last 2 weeks, actually, because the SCA's been on OPAL level 4, so they haven't been able to guarantee an ambulance going to a home birth as a priority as they used to, or they should be doing. So therefore, we've had suspended our home birth service, and the women have been really okay with that because we've been open and transparent with them to say these are the reasons why, and they just want, as long as they have their midwife that they know with them, they've come in and had a birth at Winchester or Basingstoke, and they've been happy with that. Remind me what your first question was. It was
the stillbirth rate, being higher in certain
Black and Asian mothers, I think.
And also deprivation generally.
Deprived.
Yeah, we have really small numbers in our area. So therefore, when we do have a sad case of a stillbirth, it does increase and it makes the numbers look bigger than what they actually are. But we are working towards the Saving Babies' Lives version. Care bundle version 2. So we put a lot of antenatal surveillance in place. So a lot of these ladies will have additional scans for growth. We do a lot of work regarding public health and the CO monitoring to quit smoking. So we do wrap around a lot of health and wellbeing messages around these ladies. And also we've got the continuity of carer teams that look after this particular group of women as well. So therefore they really get to know their midwives and they really get to have extra additional care throughout the maternity services. Again, I don't know about Royal Berks about their home birth service situation, but for us, certainly over the last 2 weeks, we've had to suspend that.
Thank you. Does that answer your question, Councillor Linden?
Yes, I just got a quickie for Sarah after Councillor Moore, Chairman.
Yeah, thank you. Councillor Moore.
Thank you, Chair. And I see, yes, Sarah on the call. And my first couple of questions was about the CQC thing. I was a little puzzled. We have as part of the pack the report that you did, and I started off a bit uncertain about overall rating inspected but not rated, and then we quickly got into requires improvement. Can you unpack that for me? I think I've got a view on what I think is happening here, but it's probably better coming from you.
So I'm not representing CQC. I'm representing the trust. But basically,
I was just going to say thank you.
Your Zoom title says CQC on it, so apologies.
Apologies. I should have. I'm CQC in terms of Hampshire hospitals. But just so basically, the service, it's the maternity service. I can answer the question anyway. But the maternity service that was rated requires improvement. The overall rating for the trust has not changed, and that's what those two comments mean on the reports. Does that make sense?
Yes, that's what I decided it probably did amount to. And then I'm just interested as well, the inspection was done on the 16th of November and the date of the publication of the report appears to be the 28th of January. Can you talk me through how the feedback, the sort of immediate feedback from the inspection goes? I'm just hoping that 2.5 months doesn't go by whilst the trust is assuming all things might be okay, but could start doing the improvements.
Oh no, definitely. I mean, this can be a Faye and I question because I started with the trust at the beginning of January, but they had already done a significant amount. They drafted an action plan immediately after they'd had that initial feedback from CQC back in November, and yeah, a number of the actions. I mean, I think the fact that we're actually at 54 actions complete as of today out of the 64 is it's testament to the fact that we have moved quickly with all of the improvements, and there's been a huge amount of staff engagement with all of the improvements at all levels, from sort of maternity support workers up to the matrons and the deputy heads of midwifery. Everybody has been involved in the improvements, and we've also done some mock CQC inspections. So external people from the maternity service who have come in from governance, from other divisions within the hospital, and done some mock inspections to test the improvements and to test the actions that we're saying that are complete on the action plan, to see whether they truly are embedded and sustained and completed.
Thank you. One more quick question, if I may. I noted, and it's a thing obviously for those of us here in West Berkshire, where our residents will either go to Hampshire, to Basingstoke, or to Royal Berks. There's a little bullet point that says complex care plans are printed for women that are having their babies in Royal Berkshire. And it sort of led to another wider question, which is about electronic transfer of data. Some anecdotal evidence, not necessarily relating to maternity care, but other types of care, where there seems to be a bit of difficulty moving data between different trusts. And I was just, electronically, I'm assuming in this case, does it all rely on paper, or what are the difficulties in moving the data electronically?
We have.
You want to talk to maternity, Faye, and I can talk more broadly. You talk about maternity.
Yeah. For maternity, we don't have the same systems. So we have Badgernet, whereas Royal Berks have their own electronic system, and therefore they just don't connect. Which is why when the women from West Berkshire see the two different maternity systems, therefore they've got their electronic handheld notes on their iPhone or their iPad that they can absolutely share with the midwives in Reading. But actually, we found that if we printed it out and gave the woman a copy, that when she went into labour at Royal Berks, she could then just hand it over, and they would then be able to do what they needed to do, either scan it into the electronic records in Reading, or whether they would use it and just put it in their notes, because I don't know how far ahead Reading are compared to us with if they still have paper records, or whether they've gone all electronic like what we've done.
And the electronic system we've got in maternity covers the whole of Hampshire and the Isle of Wight, doesn't it, Faye? So it is more straightforward if somebody's going from Winchester to Southampton, say, but it's the boundary around the integrated care system boundaries makes this a bit clunkier.
Thank you.
Can we hope that there might be a medium-term solution to this? I mean, is there nothing from NHS England saying, please talk to each other, trusts?
So across all services, not just maternity, there is a growing desire to be able to share information more in a more straightforward way. There is already a national spine that GP information is accessible almost, wherever you are to some extent, small amounts of that information. And across Hampshire, we've had the Hampshire Healthcare Record, which is now called CHI, which shares a lot of information as well. But what NHS England are doing, and I can see Amanda on the phone, she may be more recent insight than we do, but we very clearly hear that it's about setting expectations around the ability to share information from systems. So ensuring that systems are interoperable, or that information can be shared between systems, and putting standard protocols in place to make that more straightforward. So there are some standards coming out of NHS England around digital systems to make that more possible. But it's not about everybody being on the same system.
Okay,
Amanda's nodding. Yes, yeah. Great. Okay, thank you. Thank you very much. Does that answer your question, Councillor Moore? Councillor Linden.
Yeah, I'll just add to that we also need to consider the other three nations of the UK as well, and possibly further afield when people go on holiday, for instance. So that is, I think, a key point, that we do able to electronically discuss things for the health of the public.
Thank you, Councillor Linden. I just have a couple of questions, if I may. Obviously, you seem to be on track with the recruitment. I just wondered if you could just share with us what sort of the main barriers to recruitment are, because that was my understanding. And also, on a separate question, how you are going to help with the mental health of the midwives and keeping them motivated and keeping them retained. I don't think you covered that, because you covered an awful lot. Thank you.
Yeah, that's fine. So the barriers for us with regards to recruitment is we're all fishing in a really small pond. So obviously we have to recognise that we are surrounded by Royal Berks, Oxford, Salisbury, Southampton, Portsmouth, so everybody's looking for the next midwife as soon as they qualify. I think for us, we are having talks with Winchester University, see if they can do a maternity midwifery course, that's more local for us, so that might be more attractive. Obviously, we do have student midwives that travel from Bournemouth, because we host Bournemouth University, and then they don't always stay. So retaining more locally grown midwives is most probably our ambition at the moment. We're also looking at MSWs going on the apprenticeship courses. I know that when Alex has been walking around maternity, they always ask her about this route. And again, we're absolutely exploring this because that would be really helpful for us. Again, for the MSWs are just fantastic. And I think, for a career progression, we need to be harvesting that. And again, that will retain our staff. Return to practice midwives is coming back into vogue, and we have got space for another 6 return to practice midwives. If we can find them, we are advertising to say that we will support their placements with us. Again, we've got some international nurses that work on our postnatal ward, and they've all expressed an interest in doing the midwifery shortened course, which we can hopefully support that. Again, it's funding and something to do with their visas that we're just trying to unpick at the moment. And again, if we're successful with the International Recruited Midwives programme, we most probably carry on doing that as a rolling year on year. At the moment, this is just a pilot for us for this year. So if that's really successful, then we'll carry on exploring that route. We're also going, we're meeting with colleges and schools, trying to get in the early doors to secondary schools to say this is a really good job to do. So we're doing all that we can. Yeah, absolutely. And to answer your second question about the mental health, we do have practice midwifery advocates, and we've just increased our workforce to ensure that we have this training and support for our midwives, so they are available. The trust actually has a health wellbeing hub as well that people can access at all times. Comms are really good at advertising help groups and contact numbers. We have a good chaplaincy service as well. Then come and speak to their line managers. We've done TRIM training as well. So if they've had a traumatic experience, we've also had external psychologists come and support us with debriefing sessions. So we're putting as much as we can in to wrap around them to show them that we care, and that actually, their mental health and well-being is really quite a focus for us, especially after COVID.
Yeah. Faye, I just wonder whether it's worth just saying about the specialist midwives as well. There's when I've been working with these guys, there's a number of specialist midwife roles which is going to also support with that retention piece as well. So whether it's about fetal monitoring or about quality assurance, lots of opportunities there for specialist midwives later on as they progress down their career. So I think that's really important for the retention as well.
Yeah, that we have a lot of internal jobs that we advertise, and our staff actually go for those. We've had clinical matron roles just recently been out for advert, and also the deputy head of midwifery for Winchester. She was an internal candidate that was successful after a really robust competition, really. So that I'm really pleased that these people are really putting their hands up and coming forward for these roles.
Thank you.
We make a lot of opportunities for them, so hopefully we can keep them.
Thank you very much. That's very interesting to hear. Members, are there any other questions? No. Well, I'd really like to thank all of you, Alex, for bringing your team, every single one of you, and for doing such a comprehensive presentation. I think it's very important not to lose sight of the fact that it's just the maternity services that we were looking at today, not the overall CQC rating. So thank you very much, and thank you for coming along.
Pleasure. Thank you.
Thank you.
Welcome to stay if you want.
Thank you.
Thank you. Okay, so members, there's no recommendation associated again with the report. We're just simply asked to note the report. So moving on to agenda item number 7. So this is the protocol, the West Berkshire Health Scrutiny Committee protocol with other local health bodies. Basically, this I hope you've read all the actual protocol itself, and the recommendation is to endorse the final protocol and process for dealing with the proposed substantial developments of variations to health services, and secondly, to recommend the protocol for approval by the Health Scrutiny Committee. We did, as you know, take this to consultation, and a joint response was received from Berkshire Healthcare NHS Foundation Trust and the Royal Berkshire NHS Foundation Trust, who are both supportive, and there's no actual objections or suggested amendments that we've received to the protocol. Does anybody have any comments or anything they wanted to raise on the protocol. Councillor Moore.
Thank you, Chair. Yes, I'm still concerned that the protocol, as it stands, the version I'm looking at, doesn't have a list of the organisations with whom we are developing the protocol. And given the rather variable response to the consultation, I think the protocol needs to say, we are expecting this protocol to operate between us and the following bodies, and give an indication as to what sort of response we've had from those bodies. I'm very supportive of it otherwise, but I'm reluctant that it goes forward without that addition.
Councillor Moore, I understand that we've sought advice from legal, and they have actually advised us not to specify which actual bodies should be sort of named as the list. I think the whole point of this is that it's a wider protocol that we share as our protocol, as our West Berkshire protocol, that we have agreed. We've sought consultation for any amendments. We've sought, we shared that widely, and I think there's a slight danger that we, if we do start listing specific bodies that we just have agreed this protocol, then potentially it precludes us from working with others on that basis. I'll bring in Councillor Bridgman in case he's got any other comments on that.
Chairman, thank you. Yeah, I'm always wary of a protocol which is between one body and a host of other bodies who haven't actually potentially engaged in the discussion process. I'm reminded of the Thames Valley Police protocol on dealing with traveller incursions, where West Berkshire Council was quite, well, as members, we were quite surprised that there hadn't been any discussion with members about what it might contain. And we had some concerns about what it said. And this was, it was more of something that Thames Valley imposed upon all of the local authorities that it was dealing with as how it saw the rules of engagement. And I see Councillor Macro nodding because we had some fairly robust comments to make about the use of, from memory, Section 60 powers. So I use that as an example where I am concerned where this authority is seen to be imposing its protocol. It's absolutely right that we have rules of engagement, that we say, that this committee says, this is how we see the game, this is how we see the field of play, this is how we are going to approach our discussions with other health bodies. But to expect that somehow by creating a protocol, the other health bodies will naturally sign, they may sign up, great if they do, but I do think there's an element of signing up to this. And if we've only had Berkshire Healthcare and Royal Berks effectively engage in the process, I have a concern that we are seen by the wider health community, GP practices, for example, to be saying, well, this is how guys have got to operate. And they go, well, no, it's not, because we'll decide how we operate. So I just see that tension in any document like this.
Thank you, Councillor Bishop. Councillor Moore, did you want to?
Yeah, I mean, then is it all in a name? To me, the word protocol implies, as Councillor Bridgman has just sort of confirmed, some kind of agreement between two or maybe more than two parties. If this is put out and published as our take, and I can't think off the top of my head what alternative word I might propose instead of protocol, but the point is this is if you like from our side what we think of the rules of engagement. At least it's out there. But it just it's the word protocol then in that case. If legal are telling us that we can't get these other bodies to be listed and agree, come up with something different, please.
I think it was an advice, really. It wasn't we can't do certain things. But do we have any comments from any other members or any thoughts on this? Councillor Linden.
Yes, I think for our scrutiny to work, and this is wider scrutiny as well, and also the Health and Wellbeing Board, we do need to have engagement, and it is important to encourage them that, you know, we have a joint requirement to improve health in, as far as we're concerned, for our 158,000 residents, and in particular our most vulnerable adults and children as well, and public protection comes into it as well, so including environmental health part. But it is important that for the well-being of our residents that we do have that degree of cooperation, and that should be encouraged. Thank you, Chairman.
Thank you, Councillor Linden. Amanda, did you want a hand up from?
Yeah, I'm just trying. Sorry, my laptop doesn't recognise Zoom, so I'm like I'm trying to run off my personal iPad, so I do apologise. I was just going to say, hopefully the next paper will help. I haven't seen that the paper that you're referring to. I haven't got a complete set, but if when we talk through some of the engagement, because I agree, it's with the direction of travel that we are moving towards with ICBs and ICSs and place-based partnerships, absolutely that collective responsibility for the health and well-being of our residents and population should be one that's considered a joint endeavour. So I agree with that, but I can't comment on the particular protocol because I haven't seen it.
Thank you for that contribution. Well, members, we do need to decide if we want to propose this and second this recommendation. Do I have a proposer? Councillor Linden, do I have a seconder? Okay, members, is it the actual what? Yeah.
Sorry, I'll second that. But reluctantly, really, because I do understand where Councillor Moore's coming from. But if legal have advised us and that not to put this list in, then I think we must accept that.
I wonder if it's worth revisiting this, if members feel more comfortable to do.
I'm sorry?
I'm wondering if we revisit this, if members would feel more comfortable to explore it further with guidance from legal provided, and also maybe to frame the wording of it. I mean, where we say protocol, is it a framework, rules of engagement? I wonder if there's a bit more comfort that we can get from this before we actually vote on this. So I don't want members to feel reluctantly about seconding or proposing. Is that something that the committee would feel more comfortable with? Councillor Linden.
Yes, Chairman, I think we had a very useful pre-meeting amongst ourselves with the officers. I would like a senior legal officer to turn up at a future pre-meeting. I don't know if Sarah Clark, Mrs. Clark was involved with this, or whoever was, but it would be useful that we could do it on a senior basis, that we can have it in a pre-meeting, and if they wish to attend the next meeting, that is advisable, because if we got unease, which evidently we've got, and concerns, because there are things missing from it, that it would be useful that we get the best information and come back at our next meeting, Chairman.
Thank you, Councillor Linden. Councillor Moore.
I would welcome your suggestion, Chair.
Yeah. Thank you, members. Well, I think let's do that. Let's bring this back to committee at a later stage and get a bit more information, and so that members feel a bit more comfortable. Okay, so thank you. Moving on to agenda item 8, and welcome to Belinda Seston from the Health Scrutiny Committee, and also Amanda Lyons. Thank you so much for waiting all this time, ladies. The floor is yours to provide your update.
Thank you. Belinda, do you want to go first to give a local context, and then I'll step up to the system?
Yeah, sure. Thank you for the invitation. So I'm the Interim Director of Place Partnerships. You may well be aware that Katie Summers is now on secondment, so I'm now on day 3 into the new role. Very helpfully, Katie has prepared a briefing, so I'll take you through some of the kind of the key items. that are relevant to this meeting. So you will be aware that Hampshire Hospital, we've just had the Chief Exec on our call, are modernising their hospital programme, and I suppose the first update is that I am actually involved in that. I know that Nigel Lynn, who is the Chief Exec of West Berkshire, is also in attendance, and going forward, both Nigel and myself will represent the options that are being considered in terms of the new build. So, and also to consider any wave effect from the changes with the new build as well. I'm aware that around 4% of Berkshire, West Berkshire residents may be impacted, so we're looking at that impact assessment at the moment. In terms of winter access, you will be aware that GPs have been very, very busy providing COVID services to their local residents. And there has been an access fund which has increased the amount of activity that GPs can undertake, so that we know that there have been additional over 21,000 appointments, both GP and non-GP appointments, which equates to an extra 500 GP sessions. What I would need to just clarify is whether that is specific to Berkshire West or whether that is across the BOB. So if you can just hold that caveat in terms of the figures. You may be aware of conversations happening around a hospital discharge service. Susan Parsonage, who is the Chief Exec for Wokingham, is actually taking the lead across the Chief Execs to lead on this matter. And I'm aware that it's still subject to some discussion. The Ukraine crisis has obviously provoked a response across sectors, and Dr. Tracy Daskuski is taking a lead on that. She's the Public Health Director for Berkshire West, and she's been supported with Julian Ems as well, who's the Chief Executive of the Royal Berkshire Mental Health Trust. So they're developing a task group, and actually we're going to be having further discussions on this matter at the next Unified Executive, which is our ICP lead executive group. And then finally, due to COVID, there's been a significant impact on elective care. And so the main initiative has been to reduce patients waiting over 104 weeks. That's been a really, so over 2 years, that's been a really big focus. So the expectation, there's a very clear trajectory to make improvements in this area. And so by spring 22, so really any time now, there will be no patients waiting over that 104 weeks. And obviously there will be a continued trajectory to actually bring that down further. So further updates will come to this board. So that's my Berkshire West update. Going forward, it will be hopefully much more comprehensive as well for you. And I'm very happy to take any questions.
Thank you. Members. Councillor Linden.
Yes, whether it's you, Belinda, or Amanda. The chairman and myself are representing the council on Bob, and we haven't had a meeting yet. I just wondered what's happening with the progress there, that we may be able to get things going there on a wider area, which is important. And obviously it's also important as far as Wokingham and Reading are concerned with this as well. So I just wondered if there is a further update on that, please.
Shall I hand over to you now, Amanda?
Yeah, I was going to try and put my headset in, but we absolutely. Councillor Linden, I will take that away to double check where that is in terms of meeting with the chair. But if it would be helpful, I can give you a bit of a wider update in terms of the ICB and ICS development, which hopefully will answer some of those initial questions for you. So the transition of the to the ICB as a statutory organisation is subject to royal assent still, but 1 July is the date we are continuing to work to, and I'm pleased to say that that is continuing with good progress. We've been developing a 12 to 18 month transition roadmap, which enables us to set out the both the what I would call the sort of technical setup of the ICB, so we call it the architecture, but then look at the more developmental areas of the ICS and some of the key enablers. To give you a bit of a flavour for that, the architecture is very much looks at the governance between the place-based partnerships and the ICB and the ICP. The ICP being the partnership organisation, which includes local authority members, the ICB being the NHS statutory body, which forms the NHS across the three areas. It also includes that technical and functional integration, which is very much, have we got one general ledger? Have we got one payroll for the staff who will run this organisation? And it also looks at the formation of the board and the appointment to substantive executive positions, and then the staff, because the functions are different from the CCG of this organisation, and how that all comes together and how we will interact as the NHS with the region, but also taking into account the recent February white paper, which is the integration white paper, which requires quite a lot of thinking with our local authority colleagues across each of the three places as to what that means for place-based partnerships. So that's sort of part one. Part two, which and the ICB architecture is quite, not formulaic, that's the wrong word, but sort of quite organised, it's under control for 1 July and needs to be. The ICS development aspects are the more forward-looking aspects, and we have really turned our mind to that. That includes provider collaboratives, and I'll expand on that a little bit for you in a second. It includes the place-based partnerships, of which Berkshire West is one of the three in the across the and there's a lot of strength in Bob ICS compared to others in the region in terms of the strength of its places, which is great and is really good for that local focus. And the delegation therewith and the arrangements between that are covered in the white paper. We've also starting to think through what is the ICS strategy and how does that fit with Health and Wellbeing Board strategies, and what does that mean, and what are the benefits of scale and as opposed to the local populations. And the final and what is the public engagement that needs to take place as a result of that, and system financial framework. There's some key enablers which we need to consider, which is very different really from how the CCGs would have functioned and can be strengthened, and are part of the 4 core objectives that an ICS should have set out in the legislation. So real focus now on digital and data and BI. So we were talking about connectivity in maternity services, but we also need to think about that across even locally across the ICS footprint. It looks at clinical and professional leadership that needs to be strengthened in order to change those pathways. So the patient from the moment they touch the become, well, even before they become touching the NHS, but actually what's the preventative part of the pathway until they leave the care of the NHS. Also thinking through, have we got it correct in terms of the diversity and inclusivity of the way we work and the way the staff work, and the culture we wish to bring to locally and to the ICS. Also how we tackle inequalities, learning from each other and what we should be doing there. And finally, I'm an auditor by background, but actually the assurance that we can give both yourselves and ourselves that actually where the outcomes we wish to achieve are actually achieved. And I think there's more we could do there to be clearer. So that's the work, and that's the work stream. And I will send a link for you to a presentation that went to the governing bodies that would be helpful to set that out. I think that would be useful for you to see, and so on. We have developed that further, and we will update that in April in line with some of the NHS requirements. If I pause there, then happy to take questions.
Thank you. That was very helpful. Councillor Bridgman.
Not really a question, perhaps a clarification and comment. Firstly, I just have to say, welcome, Belinda. I will be seeing you in Health and Wellbeing Board, no doubt, in the not too distant future, in place of Katie, and so welcome aboard. Just to correct that, Julian Ems is the CEO of Berkshire Healthcare, not Royal Berks. Just to make that for the record. And of course, you'll know, Chairman, that you and Councillor Linden are on the JHOSC for Bob, not on the sort of integration piece itself. As it happens, I will be the Berkshire, the West Berks rep on the ICP. And indeed, the leader and I had a conversation with Javid Khan, who's chairman, and with James Kent, CEO, last week. And we're just waiting for a meeting to be set up of a working group, which is going to be looking at how the ICP operates going forward. Certainly, we are very interested in the PBP, the place-based partnership aspect, because apart from anything else, as Belinda knows, the CCG has a statutory role in relation to health and wellbeing. Well, the CCG is disappearing. So where is that statutory role going to lie in relation to the relationship with Health and Wellbeing Board? And then going forward, yes, there will be clearly a role for scrutiny in relation to Bob and indeed the place-based partnerships within it. But then there's also the question of how the whole beast operates. And as I say regularly, and I said to Javid in our call, where the money is, because that is going to be one of the critical pieces from our point of view. And indeed, in anticipation of something that's coming up on the agenda, the relationship with the CCG and continuing healthcare is certainly on James Kent's list of things to look at, because it seems ridiculous to have a system where you have different ways of operating in relation to continuing healthcare. Oxfordshire operate one model, Berkshire West operate a different model. Let's try and get some consistency here. So anyway, I make those comments rather than questions. Thank you, Chairman.
Thank you, Councillor Bridgman. Councillor Moore.
Thank you, Chair, and thank you for the presentation so far. I'm sorry, I'm struggling a little here. Okay, so we had a paper as part of our advanced pack, and I thought I had just got my head around ICBs and ICSs. I now hear ICP. Could somebody unpack that? And while they're doing so, talk a little bit more about provider collaboratives, please.
Thank you. I'm happy to do so. And I did say I would come back to provider collaboratives, so thank you. So the ICB is the Integrated Care Board, which is the NHS statutory body, which will fulfil the statutory responsibilities that the CCG would have previously had. So it's the NHS arm. The ICP is the partnership board that incorporates the local authority and other partners. That it's quite an unusual construct that sits alongside, and it is all in the umbrella. If you imagine it's not a Venn diagram, but it's two things that have got a bit of connectivity with a big circle around it, which is the integrated care system. And the system is everything that sort of falls in those boundaries. It's probably the ladybird quick explanation on that. Provider collaboratives. So provider collaboratives is a group, a sort of a terminology which captures any arrangement whereby one or more NHS bodies choose to cooperate to deliver something. And you heard today of the CAMS Tier 4 provider arrangement, which included Hunter Combe, included Berkshire Health and Oxfordshire Health. It's not a statutory legal entity, but it's multiple health organisations that's come together to deliver something for healthcare. So that's our first live example of one of those, but all of the legal entities still are accountable as legal entities. So it's a way of working together in partnership. So another example that they're just looking at up in the Oxfordshire area is Oxford Health working with the OUA, Oxford University Hospitals, to look at the end of life care pathway and to look at how they deliver urgent and emergency care. So working together under one umbrella to be a bit more seamless, which allows them to move staff between each other a lot more freely and so on and so forth. So 2 live examples to sort of help you understand.
Does that answer your question, Councillor Moore? Thank you. And Amanda and Belinda, I don't know if you're aware, but we're fairly sort of new health scrutiny committee in certain respects. We've only been sort of going for just under a year. So we're still getting up to speed still with some of the, and they keep changing as well. So forgive us for that. And anything you can share with us in terms of visuals or anything, we would be gratefully received, I think, by the committee, if you have that. Do we have any other questions, members? No. Well, thank you very much, Amanda, Belinda, once again, for coming along and for your reports. We very much appreciate it. Thank you. And members, just to note that there's no recommendation associated with the report, so we're simply asked to note it. So moving on to agenda item number 9, the Health Watch report. I don't see Andrew on the line, no. So I hope members have had a chance to read the report. And again, there's no recommendation associated. We're simply asked to note it. And if you do have any questions, I'm sure we can follow up with Andrew after the meeting. So moving on to agenda item number 10.
Chair, sorry.
Yes, sorry, Councillor Moore, I didn't see your hand.
The pack, am I right in thinking that we haven't actually got a report? It's just a verbal item.
Was it in this?
Have we missed?
Oh,
have we missed some?
Apologies. I was actually reading this. Was I reading one report in? I was actually. I thought that it was. Sorry, it was in the main. It was in the main pack, in terms of the patient care responses, urgent care response team. Sorry, I do have one in my pack. Okay, so I've just been told it's not related to this item. So yes, it was just a verbal update. So I'll just double check what I was reading in the back end of my report.
There was something in one of the other presentations from Health Watch in relation
to... Exactly. I think that's where the confusion has arisen. It was relating to a former item, not specifically a report from Health Watch. Perhaps we could get an update from Andrew outside of the meeting, which might be quite helpful. Okay, item number 10, task and finish groups. Members, we're invited to consider the proposed terms of reference for continuing healthcare task group and agree the membership, chairman and timescale for this. I believe Councillor Bridgman may have a little bit of information on this, which might be helpful to shape our thoughts.
Indeed, Chairman. I mean, as I sort of anticipated in what I just said to our colleagues from ICS level, this is appears to be on the radar of James Kent, and therefore it's a fairly significant bit on the radar because he's a fairly significant player in this field. Certainly, I made I think our position to him very clear, which is that I think I speak for us all when we say that we're not very happy with the way we come out under CHC. And that we want a continuum between the different bits of Bob when we look at continuing healthcare, because something that I realised very early on when I took the adult social care portfolio was that we're not singing from a similar hymn sheet to Oxford, for example. And there are different matrices and ways of counting the numbers that end up with a different financial endpoint. So I simply say that it is clearly on the radar of system. Now, I know that so far as this paper is concerned, we are talking about what and this is the confusion, Councillor Moore, what used to be the integrated care partnership until not that long ago. We all thought we knew what an integrated care partnership was. It was Berkshire West. It's what is now the place-based partnership, because the integrated partnerships moved up the tree. The NHS do love churning an acronym. But there is clearly a conversation to be had with what is currently the CCG and what will become the place-based partnership. But I just flavour that with the notion that I think the system hopefully will be looking at CHC as part of its overall thinking process around the relationship between local authorities and the NHS. Take that into your deliberations as you will, and maybe our colleagues from the NHS can give us their thoughts on where we sit within that whole debate, because hopefully it's being looked at.
And indeed the timescale, I think.
Yeah, indeed.
Amanda and Belinda, I don't know if you've got any comments on that whilst we've still got you.
So it's something that I'll go back and take a look at. It isn't something on my current radar, but after the conversation today and seeing it on the forward work plan, I obviously will now put this much closer to my remit.
Thank you.
And from a system level, I do know that James Kent, as CEO designate, is absolutely cited on those conversations, because he's relayed them to me as one of the exec directors at the ICB level. I will though take it back to I can't answer on timeframes. We've just got to the year end, so we're actually submitting this wider plan into NHS England. So we're on regroup week. So, but I will with Belinda, we will take that away to make sure we understand the timeframes. But I do know it is on his radar, and he has got that as something he wants to is committed to look at.
Thank you. Thank you very much. Members, do we have any thoughts on this in terms of, it sounds to me that the sort of rug may be pulled from underneath us at some point, but do we go ahead and set this up and start working on it? Any comments or thoughts? Councillor Linden.
Yes, Chairman. I think we need to be prepared for this. I mean, we've got quite a tight time scale. And even if we have to pull the rug or make alterations, I think it is very useful that we have the outlines of what roughly we're going to do. And obviously we're working with you as chairman and the vice chairman, who I presume will be chairing this, and also our two officers here. But it is important that we're prepared as much as possible, but expecting there's going to be large scale changes, and also welcome Amanda's point that on the timescale, which she obviously will be finding out about. Yeah. I think preparedness is the key thing, even though we have to adapt to it.
Thank you, Councillor Linden. Yeah, Councillor Macro.
I think we should crack on with this, because I hear what Bob may or may not do, but things in that area seem to be moving exceedingly slowly, and I think we should get on with it. And then, if necessary, we could terminate things if things appear to be moving fast elsewhere.
Yeah, thank you, and other members in agreement. So I think we have discussed a membership, which is ideally 4. So I believe, Councillor Beck, Councillor Moore, Councillor Linden, and Councillor Macro on the task force. We can obviously go outside the committee, but I think that's what we've agreed on at the moment. And so may I propose that Councillor Macro is chairman of that, and that Councillor Linden is vice chairman, if everybody's happy with that. Do we need to vote on any of this? I'm looking at my colleagues. Or is it just to agree it with a timescale? I'm guided by my colleagues.
I don't think a vote is necessary, Chairman. I think if everybody's in agreement, then yes,
okay,
that's fine.
We can just minute it. Okay, thank you very much. In terms of timescale, I think it's a difficult one, isn't it? Do we want to come back on that? I think it's important to have a timescale. I'm just not clear on what is realistic, bearing in mind the the level of investigation, etc.
And the workload of officers as well,
Yeah.
Chairman.
Can we come back on that point if everybody's happy? But I do believe we need to have a timescale.
I think Councillor Linda has a very good point there. We do have to bear in mind that
Officers.
Yes.
Yeah, officers' workload as well. Absolutely. So we'll come back on that one. Great. Thank you very much. So moving on to the final agenda item, which is the work programme. Members are asked to note the work programme and also to seek, and if anybody's got any comments or any feedback, anything they wanted to raise. Yes, Councillor Macro.
I'd like to bring forward the item on, unfortunately, I can't refer to the document easily, to do with new development, new facilities, health facilities for new development. I think it should be health cover services as well, and I think we need to bring it forward because we're in the process of updating our local plan, and also this is something that comes up, whenever housing is mentioned on the doorstep of people I speak to. The healthcare facilities, and particularly GP services, are top of people's agenda. People say, well, I have to wait 3 weeks now. What's it going to happen when all these houses are built? So I think I'd like to bring that close to the top of the list.
So if I'm right, you're referring to item number 10, which is in facilities for new developments.
That's right. Yeah.
Scheduled for the 13th of December 2022. Can we look at that? Yeah, if we can fit that into move it up the schedule.
Please, thank you.
Thank you, Councillor Macro. Any other comments, members? No? Okay.
Sorry. Yes.
Sorry. Yes. Sorry. I haven't got hands coming up. Everybody stop putting hands up.
The first thing I wish to do, Chair, is apologise. I have just now found a Health Watch update in my pack.
It wasn't just me then.
It wasn't just a verbal item. 2 pages further down, there are pages and pages and pages of it, and I've just found the bottom end.
I'm getting paranoid about the verbal items. However, I think it did relate specifically to the former item. But when you see a Health Watch report, you assume it's going to be referred to. Thank you.
And I'm just prompted by Councillor Macro's comment about that, because I think we have to programme in the motion that was delegated out of full council.
Yes, and that is actually in the work programme for the 14th of June. The motion regarding West Berkshire hospital redevelopment.
Yeah. Okay.
And actually, we specifically didn't put it into today because of the PACT programme today. And I think that was actually the right decision looking at the timing of this afternoon's meeting. So that will be looked at in the next meeting.
Great, thank you.
Okay, any other comments? No. Okay, I think that brings the meeting to conclusion. So thank you very much once again for everybody attending. May I ask all panelists to remain in the virtual meeting room and not leave until the Zoom host has confirmed the meeting is no longer being live streamed.